Okay, so perfect.
Oh, all right. So one thing that I think Heather emailed out in the highlights, which I'm really excited about, is that the entire 2020 edition of Histology for Pathologists is available on the library website, that you can either read online or you can like go to their new website version and download all the PDFs. So if you click on the little, I'm pointing to the screen, you can't see me. If you click on the little paper clip, all of the relevant head and neck PDFs have been put here. There's also an eye one, which I can include as well for you guys. But pretty much every single organ system, you can download the PDFs on Histology for Pathologists. And I think this is a really, really good resource for people learning pathology, because it puts these general histology books into the context more of what you may need for being a pathologist. And it introduces a little bit of, like a little bit of pathology. So I really, really recommend Histology for Pathologists. So there you go. All right, so we're gonna do a normal histology. I'm not gonna focus too much on anatomy, because I'm kind of assuming we'll get through some of that when we do our gross lectures. But we'll do normal histology. All right. Now my slides aren't advancing. There we go. Okay, so just to remember sort of what kind of tissues we're dealing with in the head and neck. And please stop me with comments, questions. Like, I know, it's hard to be interactive on Zoom, but let's at least try. So the thing that I love about the head and neck is that it's so diverse, right? You have mucosa, you have skin, you have bone, you have other soft tissues, you have, ear, you have eye, you have glands. So tons and tons and tons of variety. Don't let, squamous cell carcinomas of the head and neck, scare you. There's a huge, amazing amount of variety in the head and neck. And so we're going to go over, what those normal compartments are and what the normal histology of those is. So of course, there are squamous mucosas lining the oral cavity, the pharynx, and the larynx. Remember, the pharynx is just sort of the back part of the upper airways that eventually proceeds into the esophagus. Conversely, the nose and paranasal sinuses are those areas that are more for respiration, that are lined by respiratory mucosa with lots of mucosal glands to moisten the air. We, of course, have our digestive salivary glands, the major ones being the parotid, the submandibular, and the sublingual, but there are minor salivary glands everywhere in the upper aerodigestive tract, right? The palate, the trachea. So you can get salivary type lesions there as well. My favorite organ, the thyroid, accompanied by its small parathyroid glands, we'll talk about today as well. I'm not going to go over necessarily, a lot of normal histology of skin or eye. We'll cover a little bit of bone, we'll cover a little bit of ear, but all of these compartments are relevant for the head and neck. And I'm sorry if you guys could hear, there's something weird going on outside my office, some noises. Okay, so in each of those compartments, when we think about diseases that can occur there, let's just remember that you can have things like autoimmune disease in all compartments. You can have infectious or reactive, processes, and you can have neoplastic processes. And so when we get into our pathology block for head and neck, we're certainly going to go over all of these, but just have a broad differential diagnosis whenever you're looking at these cases, because it could be any of the above. But we're going to start with the squamous sites. We're going to start with oral cavity. So remember, the oral cavity is broken up into many subsites, right? If you think about it, there's bone, there's teeth, there's mucosal linings, there's clefts and spaces. So each of these things has their own. We also just acquired this book for resident library. Awesome. I assume you mean histology for pathologists. Good. So each of these crevices can have a different name depending on sort of where you are. So it's important to understand how it's termed. So when when the specimen is labeled in such a way, you know exactly what they mean. So let's start just generically with lip, right? I think we can all understand what a lip is, but a lip, has a skin side, has a sort of vermilion area, and has a mucosal side. And so depending on where you are on the lip, that may become important. Same with the quote unquote cheek, right? The cheek has a skin side and the cheek has a mucosal or a buccal side, okay? The gingiva are specifically the mucosa lining the bone, right? So if you say gingiva, you exactly mean that that's the mucosa that's stuck on the bone. When you have the, let me think about how I'm going to run this. You have the floor of mouth that's underneath the tongue, right? And within the tongue itself, you have the anterior or the quote unquote oral tongue, which is the anterior 2/3 of the tongue. And you have the posterior or the base of tongue or the oropharyngeal tongue, that is the posterior 1/3. We'll talk about the oropharynx separately as a special site, but remember that essentially the circumvallate papillae in the posterior tongue separate the anterior / oral tongue from the posterior / base of tongue, and diseases happen differently in those sites, specifically squamous cell carcinomas. Okay. Moving up and around, we have our palate, right? So we have the hard palate, which progresses to the soft palate, which of course progresses to the uvula, the tonsils being on either side between the, palatoglossal and palatopharyngeal folds. So for example, if you have your teeth closed, depending on whether you are in a space that is inside the teeth or outside the teeth, let's think about how those areas are named differently. So if you are on the inside of the teeth near the tongue, that is the lingual area, right? And if you are on the outside of the teeth near the cheeks, that's the sort of buccal area. So when we are referring to spaces such as the gingiva, if you want to know which side of the bone of the gingiva you're on, you may refer to, I'm just going to do it on my face. Sorry, guys. This is the buccal side of the gingiva, and this is the lingual or palatal side of the gingiva, right? So buccal, lingual, okay? Or depending on where you are, palatal, floor of mouth, okay? Is it closer to the tongue or is it closer to the vestibule? All right, just a couple things to remember. Why do I point out on the right here these lymphoid-rich sites of Waldeyer's ring? Because again, diseases occur differently in that area. So if you remember, Waldeyer's ring is that circle of lymphoid-rich tissues that protect, antigens, protect your body from antigens coming in. And so you have lymphoid tissue all around. The floor of the lymphoid tissue is the base of tongue or lingual tonsil, right? So that's that posterior 1/3 of tongue. The walls are the palatine tonsils, which we generally refer to as just the tonsils, right? Those again sit between the palatoglossal and palatopharyngeal arches on the anterior and posterior sides, respectively. And you have the pharyngeal tonsil or the adenoid, which is kind of up behind the uvula, so you can't really see it without like an endoscope looking back up there, okay? But all of these sites are important for antigen presentation and for development of carcinomas differently, which of course we'll talk about when we get to the diseases. But just remember that those are important distinctions. Okay, so I'm sure, as you all know, normal squamous epithelium is so-called stratified, meaning it has multiple layers. It generally has a distinct basal layer, and it matures to the surface. Matures meaning the cells become increasingly flat with increasing amounts of intracytoplasmic or eosinophilic keratin, okay? So we talk a lot about keratinization when it comes to squamous cell carcinomas, keratinizing, non-keratinizing, whatever, but just remember that all squamous cells have keratin in them, right? Whether they are poorly keratinizing or excessively keratinizing, they are in their souls squamous, so they will always have some amount of those intermediate filaments in them, okay? So all squamous cells contain keratin, some abundantly and some minimally. And so all of the eosinophilic cytoplasm in the squamous cells is the area where the keratin resides, okay? You may see this pallor on either side of the nucleus. When you see pallor on perinuclear pallor in a squamous site, does anybody want to chat or shout out what what that is. What is that? What's the paleness made up out of? Is it mucin, fat?
Glycogen.
Yes.
Glycogen.
Yes, thank you guys. That's glycogen. So don't be necessarily thinking that all of these are like coilocytes, for example, that are HPV type of change. You have normal glycogenation of the perinuclear area and squamous cells. And when we talk about our mucicarmine or our PAS staining, we will talk about how glycogen functions with PAS. So yeah, excellent. Do you want me to do that now? I don't have a slide in here, but I could. Who wants me to talk about diastase and glycogen?
Actually, that'd be great.
Yeah, let's do it. All right. Can you see my whiteboard?
Yeah.
Yeah.
We see it. We see a screen of white. So
You see a screen of white. Awesome. Okay. It says my screen sharing is paused. I want to share the whiteboard. Yeah. Okay. Cool. So you have a cell with a nucleus, and you have some white. I'm just going to do this very casually. You have some white spaces on the side of the nucleus. Okay. And so what are our options for what's in there? We already mentioned a few. We mentioned fat. We mentioned mucin, okay, which tends to have a little bit of a bluish color, but not always. We mentioned glycogen. What other intracytoplasmic things can we see that we might want to evaluate with PAS? Sometimes, like in salivary gland, right, you might have zymogen granules. Sorry, did I steal someone's answer?
Nope.
What else? All
we
I
right.
was thinking like
oftentimes use PAS.
alpha-1
Okay.
antitryptase.
Like in liver. Okay.
Often use it for identification of microbes, fungi maybe.
Okay. So PAS in the PAS fungus can also be used to identify fungi. Yes. Good. All right. Those are all good ones. Okay. So what happens? All right. So fat is generally a very clear vacuole because it falls out in processing, right? Like fat just falls out of tissue. The only way we're able to see fat is if we don't process it in water and formalin, for example, on a cut cryo section. All right. So the only time we're ever going to actually see fat is on a frozen section. Once it gets processed, we don't see it. We just see the white hole. All right. Mucin, we do see. It tends to be a little kind of fuzzy and blurry and a little bit bluish. Glycogen also can appear much more clear. Zymogen granules certainly appear dark and sort of purple and small granulally. Alpha-1 antitrypsin more globular, and fungus, of course, you're going to see some structures, whether they be hyphae or yeast. Okay, so what happens when you apply a PAS stain, a periodic acid shift stain? All of these will pick it up. So you're going to see, well, not that. All right. You're going to see positivity for mucin. You're going to see positivity for glycogen. You're going to see positivity for zymogen. You're going to see some positivity in the fungal cell walls. You're going to see positivity in the alpha-1 antitrypsin. All right, we're going to get rid of that for now. Okay, so what happens when you apply a PAS stain and then you apply a digestive enzyme? In the literature, it's generally referred to as diastase, but in our lab, I believe the order is actually amylase. So when you're attending asks you to order a PAS diastase, it's actually PAS amylase. So same thing. Okay. So mucin, right, is diastase sensitive or resistant?
You're resistant.
Sensitive, right?
We have a couple votes for sensitive. All right, mucin is diastase resistant. Yes, thanks, Riham. So mucin will not get digested out with diastase, okay? Glycogen is diastase sensitive, so it will get digested out, okay? Zymogen granules are also diastase resistant, so they will be retained on the stain, okay? I don't know about alpha-1 antitrypsin. I don't do liver. What is that? Is that sensitive or resistant?
Isn't that one supposed to be resistant? I have like a
sure
vague
hope so.
memory of Dr. Hart teaching us this years
Awesome.
ago.
Great. Okay. All right. So, and fungus, we don't usually do a diastase on because we see the organisms and that's enough. Okay. So when you are dealing with a vacuole in a cell that you don't know if it's mucin or glycogen or alpha-1 for that matter, or even a zymogen granule, the ones that will stain with the PAS and be digested out with the diastase is glycogen. All right, so you should often have that staining pattern in a squamous epithelium. Okay, so those vacuoles you can confirm are glycogen if they digest out. All right, when you're dealing with like an adenocarcinoma or a salivary gland type neoplasm or a lung type of neoplasm, you'll be able to see the mucin retaining. Again, if you're dealing with a salivary type neoplasm or a pancreatic type neoplasm, you'll be able to see the zymogen granules being retained, etc. All right, does that help? Okay.
Yes.
Cool. You may read about a couple of stains for fat. These are oil red O or Sudan black. These, again, you can only perform on frozen tissue. So if there's ever any indication for you to actually do a fat stain, you can't, again, you really can't do it on formalin-6 paraffin embedded tissue. It has to be done on frozen cryosections. The circumstances pathologically in which fat stains are sometimes useful. Does anybody know a couple circumstances in which fat stains may be useful?
The last situation I was aware of oil red O having no utility was back when we were talking about patterns of vaping associated pneumonia. There was some utility for that in cytology.
Okay.
But as far as surge path, I'm going to defer.
Okay. So some kind of lipoid pneumonia in
Like in neuro, do they sometimes do it for, I feel like I've seen Sudan black like in a histology atlas for some neuro slides. I don't really know what the
for
utility.
the myelin or perhaps?
Yeah, for myelin
Okay.
sheaths, but I don't know really diagnostically like if it's used.
Right. We have a couple answers here talking about liver. Okay, so identifying actual steatosis and size in liver. Okay. The other two options I'm going to mention are going to be, this is not really used in practice anymore, but it used to be used in parathyroid to identify both intra and extracellular fat. The amount of fat is inversely proportional to the functional activity of the cell. So more fat, less function, less fat, more function. So this was used to identify like lesional or hyperplastic parathyroid glands. Okay. The only other like tumor that I can think of where fat is helpful, can anybody think of a tumor? Something that happens on the eyes.
Eyes.
Sebaceous carcinoma.
Thank you, Fuad. So tell us about sebaceous carcinoma.
Well, yeah, it happens around the eye because you've got meibomian glands there, which is sebaceous glands, and it's an aggressive tumor. The nuclei look typically smudged and indented, and yeah, I don't think it's done anymore, but they used to get oily red O sometimes when they're doing frozen sections or when they were suspecting it. Now they go for things like maybe androgen receptor or EMA.
Adipofilin.
Adipofilin, yeah, adipofilin is a good one. But yeah, adipofilin seems to be like the most specific and sensitive.
Cool, thank you. So bottom line being, if you ever think you want to look at fat, always get fresh tissue and cut or get from frozen sections. Ryan, I think, has the ability to do minimally an oil red O or a Sudan black. I think we've done this very, very rarely in the past, but just keep it in your head. In the rare event that you ever want fat, we can do it, I believe, just not very frequently. Okay, because as you heard, there are other indicators and other mechanisms of immunohistochemical stains and stuff that we can use. Okay, awesome. Lipoid pneumonia, that was the thing that came out with the e-cigs, right?
Yeah, well, very early on, they thought it was calling a lipoid pneumonia pattern, but I should actually clarify that I think that they've since moved away from that. That lipoid pneumonia is a distinct pattern and not what you actually see in vaping associated pneumonia. I'll get back to you on what the actual pattern is.
Okay, cool. All right, let me reshare that. All right, you can see the PowerPoint now?
Yeah.
All right, cool. So thanks for that little aside. All right, so that's squamous and glycogen and all of the ramifications of glycogen. Okay, so moving into respiratory. So we're going to look at some actual slides, don't worry. But remember that normal respiratory mucosa is pseudostratified, ciliated, columnar, right? So what does that all mean? Pseudostratified, meaning that it looks layered, it looks stratified, but every single cell sends a process down to the basement membrane and touches the basement membrane. It's just that the cells are organized in such a way that they look to be stacked on top of each other. So if you can picture it, if this is your basement membrane, right, and this is your cell, each cell, even though it may look large, has a tiny little process that touches the basement membrane, right? So if you place your nuclei, randomly and draw your cell borders, you'll be able to draw that every single cell touches the basement membrane like that. Okay, does that make sense? So this is pseudo stratified because it's not actually stratified. It just looks stratified. Okay, ciliated because there are true cilia, and then columnar because the cells are tall. Awesome. So these tend to have underlying stromal glands, right? So your sort of salivary gland type of seromucinous glands to lubricate the airways. Generally, mucosal sites are rich in lymphocytes and plasma cells because these plasma cells are secreting your IgA, et cetera, for protection from antigens. Okay, so just to look at a slide. All right, so does anybody want to tell me, just based on looking at the type of epithelium and what's under the epithelium, where exactly in the head and neck we are?
Tongue.
Sorry?
It's a tongue
Tongue, exactly. How did you know it's tongue?
because it has stratified squamous epithelium, and underneath there is a lot of skeletal muscle in it.
Awesome, awesome. Yeah, so generally a even layer of stratified squamous epithelium. In this case, it has a little bit of, downward pointing reedy. That's okay. You remember you do have taste buds and other, structures in the tongue. So if there's a little bit of papillated areas, that can be normal if you're in a taste bud rich area. And tongue has skeletal muscle bundles underneath it. Remember that actually run in 3 directions. Okay, so the muscle bundles of the tongue are longitudinal, transverse, and basically vertical. So I was like, I can't even remember my words. It's too early. All right, so the muscles of the tongue go in 3 directions. Okay, so you should not see just long parallel bundles of muscle in the tongue. If you look at higher power, you'll see that this muscle bundle is going up and down the screen. These muscle bundles are being cut in cross section. And ideally, you would also see some, here we are, going kind of across. So 3 directional skeletal muscle bundles of the tongue with a small pauci muscular area, and then the actual stratified squamous epithelium. The one thing I will mention, unfortunately, I'm sorry, I don't have a slide of it, but so these are the intrinsic tongue muscles, okay? What is different structurally about the intrinsic tongue muscles compared to the extrinsic tongue muscles?
They might have keratinization or
Yeah, the tongue muscles, not the.
okay, yeah.
Yeah.
Sorry.
The direction of the fibers.
Okay, so what's the direction of the fibers in the extrinsic?
I'm sort of spitballing here, but I'm guessing I'm guessing these are the ones that are running from superficial to deep.
Yeah, so you sort of, yeah, so the intrinsic tongue muscles, right, are 3 directional. The extrinsic tongue muscles are unidirectional. So this is only really important for knowing where you are, for example, for cancer staging. So there are different, oral cancer stages where you upstage if you're in an extrinsic tongue muscle. What are extrinsic tongue muscles? So like genio, right? Remember genio, chin and tongue, gloss, hyoid. So all of the sort of genioglossus, hyoglossus, right? All of those are extrinsic tongue muscles. They are now unidirectional because they connect structures, right? So for example, genioglossus, right, connects the chin and the tongue just in that one direction. So unidirectional, extrinsic, tridirectional, intrinsic. Okay. What else? Does that make sense? Good. All right. Anything else on tongue? Moving on. We're gonna get the base of tongue tonsil later. Don't worry. Okay. Moving down our squamous airways into the larynx. So there are a few nice things I wanted to show you about the microanatomy of the larynx, because I think we don't always remember that there are distinctions. So we have the vocal cords, the true and the false, right? We have the thyroid cartilage, which sits, sort of in front of them, right? This is a cross section through the vocal cords and the thyroid cartilage and the skeletal muscles. So we're kind of going out this way. And these are your strap muscles in front of your larynx. Okay. So does anybody want to tell me in the larynx, which cord is on top, the false or true?
False.
False.
False. So then the true is on the bottom. Okay. So does anybody want to tell me in this section of larynx, is the top cord the true cord, or is the top cord the false cord, and why? Top cord. It may or may not be anatomically relevant. Go ahead. Sorry.
Sorry, I believe that the one that's on top is actually the true cord, and the one that's on the bottom, it looks, I'm on my phone, it's terrible, but it looks stratified, maybe also squammy, and I would say that's the false vocal cord.
All right. So are you only going by the squamous epithelium?
No, I think you have to go by the glands also that are underneath each.
Okay. Yeah, because they both kind of have squamous, right? And you only really get respiratory when you're in the cleft between them, which is the ventricle. Okay.
Yeah.
So the glands and the. Can you see that on your phone?
It's so bad. I'm so sorry.
Who wants to see what I'm showing here?
Oh, muscle.
Muscle. All right. So Christina is correct for the following. So I'm going to rotate it. All right. So, whee, that's so much fun. So the false is now on top where it should be anatomically, and the true is on the bottom. The true has the skeletal muscle of the thyroaretinoid and the vocalis muscles running through it, right? So these are the muscles that lengthen and shorten your vocal cords to change pitch of your voice, okay? So that's how we know where we are anatomically. Microscopically is the presence or absence of skeletal muscle, and then the presence or absence of these mucosal glands. So yes, okay, fine. There's like a little bit of skeletal muscle in the true, the false cord as well, but the vast majority of this true cord is occupied by skeletal muscle in this sort of triangular shape. So thyroaretinoid and vocalis, only a tiny, tiny, tiny touch of skeletal muscle in the false, mostly just these glands. All right, so that's how we know the microanatomy of the larynx and where we are. The cartilage anterior to it, in this case, as we mentioned, is going to be the thyroid cartilage. Thyroid literally means shield, right? So it's sort of a shield of your vocal cords, and it's made up of hyaline cartilage. And then in front of that, right, we have our strap muscles, which are going to be connected out here. We will talk extensively about the larynx when we have specimens in the gross room, but at least I want you to be able to recognize those compartments. As we proceed down into the trachea, we basically see that the cartilage of the trachea is C-shaped, right? And there is a lack of cartilage at the posterior aspect of the trachea where your esophagus would lie, okay? So again, this is hyaline cartilage. Again, the epithelium is pseudostratified ciliated columnar, all right? And the rest of the tracheobronchial tree I will leave for Dr. Hussein to teach you. But basically, C-shape, pseudostratified. Here are your seromucinous glands, right? So your minor salivary glands and your cartilage. All right. Questions, comments? Okay. I diverge a little bit. I'm going to scoot back up into the nose because I want to show you something that I think is really nice. So I'm going to put this in an orientation that I think is helpful. Okay. So here we are looking at, oh no, that's actually, that's the orientation. Okay. So here at the top of this, we have what type of epithelium? Squamous or respiratory?
Respiratory.
Respiratory, excellent. Then we have this, which is?
Bone.
Bone, thank you. Okay. Then we have more respiratory. And then finally, down here, right, we have glands. Are these serous or mucinous? Are they white or purple?
White.
White.
Mucinous.
Mucinous, awesome.
From
Don't worry,
mu,
we'll get to
that's the
glands
outside.
more in a second. All right, and then here we have squamous. All right, so we have some respiratory epithelium, some bones, some mucinous glands, then some squamous epithelium. Then this structure on the left, which can anybody note? All right, what about this structure is remarkable?
Very thick-walled vessels.
Very thick-walled vessels, right? So very thick-walled muscular vessels with a core of bone and a lining of, it's kind of denuded. Trust me when I tell you it's probably respiratory. All right, does anybody know what site we're in?
Are we in like
Like-
the conchas?
Like the nasal concha.
Mm-hmm. Exactly. So we're in the nose. We have 3 compartments shown beautifully here. We have this dangling structure, which respiratory lining, core of bone, thick-walled vessels is specifically the turbinate. All right. So this is the turbinate. This is, yes, thanks, James. This is very vessel rich. What is the job of the turbinates, right? The job of the turbinates is to warm and moisten the air. And what do you need? You need vessels, okay? So turbinate looks like this. This is the only thing in the head and neck that looks like this. I've said this at sign out to people before, but to me, this looks like the corpora of the penis, right? Which is like super richly vascular. It's the exact same thing as in the turbinate. Okay, all right. Then you have your other anatomic sites. Then you have some bone and some of the bones lined by squamous with mucinous glands, and some of the bone is lined by respiratory. So up here where it's lined by respiratory, this is the wall of the maxillary sinus up here. All right, so this is respiratory mucosa. And what's right under the maxillary sinus? I'm sorry, guys, the palate. All right, so this is palatal mucosa, which is squamous, which generally is very rich in mucinous glands. So this is a nice section through palate, through mucosal maxillary sinus, and through turbinate. So you're not always gonna see these nice and intact. You're gonna see fragments of them in sinus surgeries and tumor surgeries. But this is what these things look like. Comments, questions? All right, well done, everyone. So now I'm going to mention a little more specifically about that Wall-Dyer's ring, just showing you what the tonsils and adenoids look like. So if you remember, the adenoids are up here in the nasopharynx, right? So the portion of the pharynx behind the nose. The palatine tonsils and the lingual tonsil, i.e. base of tongue, is in the oropharynx, right, which is the part of the pharynx behind the mouth. We don't really have any of these sites in the hypo or laryngopharynx, which is the portion of the pharynx behind the larynx, okay? So we're gonna focus on what we generally see, which are adenoids and palatine tonsils. The only time we really see lingual tonsils are for cancer surgeries, but we see adenoids and tonsils very frequently for pediatric, tonsillitis, etc. Tubal tonsils are tiny little things by your eustachian tube. We really don't deal much with those. All right, so how do we tell the difference between palatine tonsil and adenoid? And I know that when I've gone over this at Sign Out with some of you guys, you've learned this. So who wants to answer me? So just based on looking at this, are we in palatine tonsil or adenoid, and why?
It's palatine.
Because
the mucosa is more squamous than respiratory.
Right, because we're in the oropharynx, so we're in a squamous lined site. So we have a squamous epithelial lining. Sorry, the slide's a little bit dark. I apologize for that. But you have these very abundant lymphoid follicles. Remember, so if you think about how this is oriented in the person, right? The base, the part that they cauterize, is actually on sort of the lateral pharyngeal wall, oropharyngeal walls, right? And the mucosa is sort of poking out medially, into the oropharynx. So the cauterized base, which is more lateral, is out here. Sometimes this is where we see some skeletal muscle. If you're lucky, you may see a paratonsillar abscess out here in the back. Okay, so don't forget to look for that. In the mucosal side, you're going to see your squamous epithelium. And then very characteristically, the squamous epithelium is going to dive down into this more frond-like raggedy epithelium. This is the specialized reticulated epithelium of the tonsillar crypt. And so it may look like a meshwork or a network. You can see that the squamous epithelial cells, which are these more plump cells, are being intermixed with, where's my drawing? With lymphocytes. Ooh, that doesn't show up well at all. There we go. Right, so clusters of lymphocytes are present in between the epithelial cells. That's very characteristic of the tonsillar crypts. And when we talk about squamous cell carcinomas arising in the deep tonsillar crypts, this epithelium is specialized, meaning it doesn't really have a discrete basement membrane. It has lymphatic channels that are intermixed with the epithelium and with the lymphocytes. And therefore, any cancer that arises in these deep tonsillar crypts is an invasive carcinoma. We'll talk about all of that when we get to our disease section, but I'm mentioning it to you now as we look at normal. Compare the tonsillar crypt reticulated specialized epithelium to, as you round the corner to the actual surface of this epithelium, it's different, right? This is pretty much normal stratified squamous epithelium without that reticulation, maybe with a few intraepithelial lymphocytes, but not as many, maybe with a little bit of a clearer basement membrane. All right, so the surface of the tonsil is slightly different than the crypt of the tonsil. All right, but both the tonsils and the adenoids have that same crypt structure. The difference is that the adenoid is lined by our favorite pseudostratified ciliated columnar, right? Because it's up in the nasopharynx, the adenoid in the nasopharynx, okay? And so if you look down at the crypts here, the crypts kind of have a transition, sorry, it's a little blurry. The crypts kind of have a transition between respiratory and squamous epithelium. That's fine. If you see a little bit of a hybrid type of epithelium in the crypts of the adenoid, that's totally normal. You can see squamous metaplasia on the surface, but at least at some point you should be able to notice the pseudostratified ciliated columnar respiratory type epithelium, and you know where you are. The two things I will mention about the tonsils and the adenoids, since we're here, we'll get a little glimpse into the pathology. So those of you who have seen these cases on the head and neck surface before, you will know that there are specific types of viral-related cancers that occur in the adenoids and viral-related cancers that occur in the palatine tonsils. Does anybody want to name what they are and what the viruses are? All right, so Reham says HPV. Where's HPV? Mostly the palatine tonsil or the adenoid? Somebody. Thank you. Palatine. All right. So you have HPV-associated squamous cell carcinomas that commonly arise in the palatine tonsils. What do you have in the adenoid? What virus? EB. Okay. EBV, Epstein-Barr virus. So these are both virally associated carcinomas that occur in the deep tonsillar crypts of either the adenoid or the palatine tonsil, okay, and generally are regarded as invasive from moment one of their inception. There are occasionally EBV negative, HPV positive cancers of the adenoids, but when you're doing your workup for your cases, mostly you're going to be dealing with HPV down here, and mostly you're going to be dealing with EBV up here. Granted, there are cancers in both sites. You don't really get EBV of the oropharynx, at least I've never seen it. But on occasion, there are tumors that are negative for both, right? So this is just the spectrum of disease in these areas. Okay, awesome. Thank you for putting up with me for that. Okay, questions before we move into salivary gland? Okay, so here are your normal salivary gland structures. So we already sort of mentioned the two types of cells that you could see are the serous cells that contain the zymogen granules, which are these purple specks, right? And the mucinous cells, which contain very pale intracytoplasmic mucin. See here how the mucin is not just water clear like fat. It's not devoid of anything. There's actually goop in there. That's the mucin, all right? That's this bluish purplish stuff. But the very, very dark purple specks, those are the zymogen granules, right? Those are the pre-digestive enzymes. So if they were functional digestive enzymes in the cell, your pancreas, your salivary glands would all be auto-digesting themselves all the time, right? So they are inactive zymogens, meaning they're released out into the mouth or, gut. Then they're activated, right? Then they're activated by cleavage to function, right? So they're not active until they are activated. They're cleaved by your ACEs in your mouth and in your gut, all right? Then they become active. Mucin is not, labile like that. So it's just mucin wherever it is. So how do we know what salivary gland we're in, right? So remember our three major glands are our parotid, our submandibular, and our sublingual. The parotid is entirely serous, right? So entirely serous. So you know where you are if you see only serous. Submandibular is mixed serous and mucinous, generally a little more serous than mucinous, but you can see these so-called serous demilunes, right? These half moons, which are present. The acini themselves are actually mixed, right? So one acinus can have a half serous and half mucinous. Those are the quote unquote demilunes. Your sublingual tends to be also mixed, maybe a little more mucinous predominant, but remember the one area that was already very mucin rich, that was a minor gland, that is your palate, all right? So your serous only is your parotid, your mixed are your submandibular and your sublingual, and then your minor salivary glands can be either mixed or mucinous only, okay? So let's actually look at these. So yeah, this is just redundant. Okay, so if you look carefully, you'll see that these cells contain little tiny purple specks in pretty much all of them. All right, so this is a nice section through a normal parotid gland. Salivary glands, right, not only contain acini, but they contain ducts, right, with which to shoot out their secretions, to be crude. So there are many sized ducts in the salivary gland, ranging from these small intercalated ducts that feed right out of the acini into these larger ducts, and then into these sort of very large excretory ducts that secrete out into the actual external world, right? So depending on where you are, you may see very, very, very small ducts within the tissue, and you may see somewhat larger ducts accompanied by arteries and veins as they start to excrete into the world. These also tend to have maybe little ciliated or microvilli or apocrine structures at the lumen here, at the brush border. I don't know if we really call it a brush border, but there we go. Okay. There can be some fat in the salivary glands, but generally when you start to get, here we go, here's a few fat vacuoles. When you start to get a lot of fat in salivary glands, think about that being an atrophic phenomenon, okay? All right. Our next gland, all right. So is this serous only, mucinous only, or mixed? Mixed, right? So it's got your serous demilunes and it's got your mucinous areas, but overall, this actually looks a little more purple, a little more serous. So this is your submandibular, right? So submandibular mixed and serous predominant. And then the next one, I guess by process of elimination, you know what the next one is. This one is also arguably mixed, but perhaps a little more mucinous predominant. So this is your sublingual. You'll notice here some inflammatory cells. Okay, so inflammation can happen in the glands from autoimmune disease, from radiation. All right, you also see a little bit of fat in the gland. So the things that you might think about for atrophy, not only is fat, but also increase in this background sort of collagenous stroma. So you can see how this ductal area here has a little bit of extra eosinophilic basement membrane material. The glands maybe appear a little bit shrunken, right, compared to the neighbors. So this is a tiny little focus of atrophy, but you may see extensive atrophy in salivary glands, especially in patients who've undergone radiation, et cetera. But just be mindful that those are the features to be looking out for. Otherwise, this gland looks pretty juicy, but if not, a little bit inflamed. Okay, comments, questions? Cool. All right. Very briefly, we'll talk about the middle ear. We don't see ear too much, but know that the middle ear mucosa, where people sometimes get chronic otitis media, or where we get little middle ear tumors, this is a cuboidal, a low cuboidal epithelium, very bland and nondescript. However, the tympanic membrane is lined by a very thin layer of keratinized stratified squamous epithelium. When we have auriculectomies with temporal bone for ear cancers, if you're lucky, as in this case, you may actually see your nice temporal bone with your tympanic membrane here. Again, lined by a thin, maybe 4 or 5 cell layer stratified squamous epithelium with some keratin debris, nice keratin debris. So this is in fact tympanic membrane. Okay, there we go. All right, we talked about bone. I'm not gonna belabor this slide too much, but telling the difference between bone and cartilage, right? Bone, as in its mature form, has lamellae with osteoblasts rimming in times of remodeling. Cartilage, I apologize, do you have a normal like mesenchymal tissue lecture, like bone, cartilage, any of that? Sorry, I could have put it in here. I completely forgot. But when you sign out with me, we'll talk about the 3 types of cartilage, or you'll read about it in Histology for Pathologists. This is one of them. This is hyaline, but there are 2 other types of cartilage that you may want to know. I'm sorry, I don't have it in this lecture. What I will talk about, however, are these structures that are present within the bones of the jaws, right, which are the teeth. And so in this case, we have, I'm going to rotate it in nice anatomic direction. Okay, so we have our surface squamous epithelium, which just happens to have carcinoma in it, because generally people aren't going to get chunks of their mandible resected unless they have some significant problem. So here we have a squamous cell carcinoma. We have our mandibular bone with the thicker, right, cortex on one side with nice lamellar lines. We have our marrow space in the middle, which is more thin, right? Thin cords of bone with much more intervening kind of fibrous, fibrovascular, fibromyxoid tissue, okay? So that's our marrow space. This is our cortex. And stuck right in it, right, is tooth. And so tooth has a few parts that you may want to know. The occlusal surface of the tooth, right, would be up here at the top. And the root is the one that's sticking in the bone. Tooth decal, if it's normal tooth, dentin, not filling, not, you know, caps, teeth will decalcify just like bone, and we can cut through them as you see here. So in the very center, this pink material with these little tiny holes in it, all right, that's the dentin. I'm sorry, it's also a little bit out of focus. There we go. These little tiny holes are the holes where the processes of the odontoblasts resided to deposit the dentin. Out at the periphery, you may have some enamel, which is more of this, I'm going to go out to the top. You may have more of this purplish, yeah, here we go. This sort of purplish structure that has almost a water line, like a line of demarcation. All right, that's the enamel. And then in the center of the tooth, you have your pulp cavity, which is, you know, a mixture of mesenchymal tissues, vessels, nerves, right? So think about those of you who had cavities or root canals. Okay. The thing that holds the tooth into the bone is this dense collagenous tissue with these small fibroblast nuclei. Does anybody know the name of this structure that holds, that tethers the tooth into the bone?
Cementum.
Cementum is an acellular, kind of ovoid, purplish structure. This is the periodontal ligament. So those of you who have or know people who have periodontal disease, right? It's this periodontal sort of ligament that gets inflamed, full of bacteria, the teeth loosen. Okay, so that's the periodontal ligament. I don't really see cementum here, otherwise I would highlight it for you. There are these little sort of purple globules. Okay. All right, so that's tooth. That's tooth. So if you have fragments of tooth or a tooth producing tumor, you'll know mostly it would be probably dentin or cementum or enamel. You'll know what that looks like, which is different from bone, right? There are no actual nuclei in here. These are just holes, spaces. Okay, whereas bone should have holes, but unless it's dead, it'll have nuclei in the holes. Okay, cool. All right, thyroid in the last couple of minutes. So remember that thyroid is composed of essentially, sorry, questions before I move on. Okay. 2 types of cells, the follicular cells that produce thyroid hormone, right? And the C cells that produce calcitonin. So metabolism and calcium, serum calcium levels. The major component are the thyroid follicular cells, which are big balloons that contain colloid, right, which is the inactive thyroid hormone. When the thyroid wants to make thyroid hormone, it actively resorbs the colloid into its apical surface it makes thyroid hormone and it spits it out, its basal surface, into the vessels to circulate throughout the body. All right, C cells generally are not visible on regular light microscopy unless they're hyperplastic. So if you start to see what look like C cells in the thyroid, chances are this is probably an example of C cell hyperplasia. So C cells can reside within or between follicles. So these are clusters of cells that have this very purplish granular cytoplasm, and these sort of ovoid nuclei, sometimes with speckled or salt and peppery chromatin. So the major difference you'll see between the follicular cells and the C cells is this abundant, granular, pale bluish cytoplasm. All right, I'm going to draw something real quick. So sometimes you may see C cells. Yes, if you're lucky, they're present in like a nice little cluster and you don't see any colloid or any follicles at all. But C cells can reside in the follicles and undermine the follicular epithelium. So even sometimes you might see a thyroid follicle, right, with your totally regular follicular cells. And then kind of underneath them, you may see some foamy, like fuzzy granular cells. Those are your C cells, okay? So don't ever think that just because you have colloid, like, oh, those are definitely follicular cells. Take a look at the character quality of the cytoplasm, because you may actually see that those could be C cells just undermining the follicular cells. Otherwise, you know, you'll also be looking for them, like I said, in solid clusters or groups. Okay. All right. Parathyroid is, you know, normally the 4 small glands that sit around the thyroid, usually on the posterior aspect. So right and left superior, right and left inferior. The 3 cell types that you're going to see are going to be the chief cells, which are the main functional cells, kind of a pale basophilic cytoplasm. The oxyphil cells are oncocytes, which have more abundant pink granular cytoplasm, and sometimes you'll see water clear cells in various proportions. In a normal parathyroid, you have about 50% fat and about 50% glandular cells. As people age, they tend to acquire a little more fat, but that's a good sort of rule of thumb, is about half and half. Okay, so here I'll show you the slides now of normal. So why do we care about looking at normal thyroid? Well, one of the reasons that I like to sort of emphasize the size of the follicles in thyroid is because when we're dealing with thyroid tumors, we tend to sort of conceptualize them or name them based on if the size of the follicle is smaller compared to normal or larger compared to normal, right? So if these are relatively normal sized follicles, they're sort of evenly sized and evenly spaced and evenly shaped, all right, that's totally normal. Once you start to get a tumor, for example, in which the follicles are much smaller than this, we might start calling that microfollicular. And when you get a tumor in which the size of the follicle is much larger than normal, you may start calling that macrofollicular. All right, so that's just, I'm showing you this now for naming purposes of tumors because it's a size comparison compared to normal. All right. Maybe. All right, so what are these structures in the colloid? These square-shaped things.
Crystals.
Crystals of what?
Is it oxalate?
It's calcium oxalate. Excellent. And so if you see crystals of calcium oxalate in this pink stuff, you know for sure that you're in thyroid tissue, not in cystic parathyroid. When we see this stuff at sign out, we'll talk about it more, but all right, let's move on since we're running out of time. Okay. The other thing that we might see in thyroid, which is a normal developmental remnant, are these little nests of bluish cells. Does anybody know what these are? I know some of you.
Multiple branchial rest.
Ultimal branchial body rests, yes, or sometimes called solid cell nests. So how do they get there? The thyroid, right? The thyroid, how does the thyroid develop? From where?
Essentially an outpouching from the sort of base to proximal tongue.
Exactly. So the thyroid gland starts as an outpouching from the foramen cecum at the base of tongue. It descends down the midline neck, and then it solidifies into the two lobes, left and right. All right. The C cells and the ultimobranchial body cells are now thought to both come from the pharyngeal pouch system, right? On bilateral sides during development. Sorry about that pouch, it got a little nasty. The pharyngeal pouch system is basically squamous type of epithelium, all right? The ultimobranchial body, the last structure to develop from the pharyngeal pouch system, gives rise to these pouches that migrate into the thyroid. They migrate into the thyroid and they carry the C cells with them. We used to think that C cells were neurally crest derived, but it's now thought that they actually also develop from the pouch system. So these two types of cells together come into the thyroid, and that's how the C cells are brought into the thyroid. And so when you're looking at this, these are basically squamous remnants of the ultimobranchial body that we sometimes call solid cell nests. They have these cleaved, grooved nuclei, sometimes with nucleoli. And sometimes, if you're lucky, which I think we are in this case, we see these clusters of paler cells with a little bit of granular cytoplasm. What are they? C cells, exactly. Oh, I like that, C cells. Yeah, so these are C cells, and sometimes you see them with the ultimobranchial body. In this case, we got lucky and we did. This is probably not a case of C-cell hyperplasia because you can expect to see them in the context of the ultimobranchial bodies, but we may want to throw a calcitonin stain on there and see if they're positive. All right, so that's totally a normal structure in the thyroid. I don't even mention it because it's so normal. Okay, just I'm going to show you one other thing. Just to remember, the development of the neck is all very complicated. So not only with the thyroid and the parathyroid, but you may see some other like structures in and around the thyroid just because of the developmental migration in that area. So sometimes you have thyroid glands parathyroid glands that are completely intrathyroidal, as in this case. So you can get normal intracellular parathyroid, and you could even get intrathyroidal, for example, parathyroid adenomas, of which this is. So this thing is completely enveloped within the thyroid gland, and the only way they're able to get the adenoma out is to take the thyroid out itself, all right? So just remember that you can have parathyroid tissue right next to the thyroid or actually in the thyroid itself. The other thing that you can a lot of times see in association with thyroid and parathyroid in the neck are these things. So one of them are salivary type glands, right? So serous mucinous, seromucinous, again, because of the branchial cleft development. So you here see seromucinous glands with a little duct, and this structure is right butted up against the thyroid. The other structure that you sometimes see, and I really, really apologize, I didn't put a slide in here, but we'll see it certainly in sign out, is thymic tissue. So you can often see atrophic thymic tissue. So thyroid, parathyroid, thymus, salivary, ultimobranchial body rests, those can all happen together. And I just have here an example of basically a completely normal parathyroid gland, just for you guys to review, with some adjacent skeletal muscle and then maybe a little baby lymph node. Okay, so that's all I had for normal. Does anybody have comments or questions? Sorry, I went a little bit over.
This was really good, I would say. Thank you.
You're welcome. Next Monday, I'll pause recording.